Scientist webinar. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host and moderator for today's webinar. Today, Dr. John Krystal will present a webinar entitled Pharmacotherapy of Post-Traumatic Stress Disorder. The Brain and Behavior Research Foundation is dedicated to funding research around the world to identify the causes, improve treatments, and ultimately develop cures for mental illness. The Foundation has awarded over $300 million in research grants over the past 25 years. As you know, yesterday was Veterans Day. A number of service members, veterans, and their families are participating in this webinar, and I want to thank each of you for your service to our nation. PTSD is one of the invisible wounds of war, and I encourage anyone with this condition not to suffer in silence, but to seek out the treatment that you deserve. One of the leading researchers on this important topic is today's presenter. I'm delighted to introduce Dr. John Krystal. Dr. Krystal is the Robert L. McNeil, Jr. Professor of Translational Research and the Chair of the Department of Psychiatry at Yale University School of Medicine. He is also Chief of Psychiatry at Yale New Haven Hospital and the Director for the National Institute on Alcohol Abuse and Alcoholism at the Center for the Translational Neuroscience of Alcoholism. He's also the Director of the Clinical Neuroscience Division at the VA National Center for PTSD. In addition, he serves as Director of the VA Alcohol Research Center and the Medical Director at the Schizophrenia Biological Research Center at the Department of Veteran Affairs. Dr. Krystal is an expert on the neurobiology and treatment of schizophrenia, post-traumatic stress disorder, and alcoholism. In these areas, he has linked experimental psychopharmacology, neuroimaging, and genetics to identify disturbances in the function of brain circuits that might be targeted in the development of new treatments. He developed the use of ketamine to investigate the role of glutamate in a variety of psychiatric disorders that led to novel treatments for schizophrenia, depression, and alcoholism. Dr. Krystal is a 3-time NARSAD grantee in 1997, 2000, and 2006. And for the past decade, he has been a voluntary member of the Foundation's Scientific Council. The Council helps to identify the most promising research grant projects to fund each year. This event today will be an interactive event. We'll start with Dr. Krystal's presentation, followed by questions and answers. To submit your questions, please use the Questions tab of the webinar control panel. You can submit your questions throughout the presentation. As your moderator, I will present your questions to Dr. Krystal, and we will address as many as possible. And now I'm pleased to present Dr. John Krystal. John, the floor is yours.
Very good. Let me get my presentation up. So Jeff, thanks so much for the opportunity to speak about post-traumatic stress disorder, which, as you know, is an extraordinarily important consequence of exposure to extreme life events, which we sometimes call in shorthand traumas or traumatic experiences. And I think that to speak on the day after Veterans Day is particularly meaningful, and I appreciate the timing of this. I also wanted to just also say that it's a particular pleasure to speak on behalf of the BBRF because it is such an extraordinary and important organization that's, as you've mentioned, been important to me in my career, but also to countless numbers of other investigators to help to make breakthroughs for mental illness. So today I'm going to be talking about the medication treatments for post-traumatic stress disorder. And as you've mentioned, that my general strategy in terms of the way that I think about these medications is how we can move from an understanding about what's happening in the body and brain to try to develop in a rational way and to think about in a rational way the medications that we use to treat post-traumatic stress disorder, or PTSD. Let me acknowledge before I go further that I have consulted to a variety of companies who are trying to develop new medication treatments for psychiatric disorders, predominantly schizophrenia and depression, but some nowadays post-traumatic stress disorder, and that the opinions that I'm going to share are my own opinions and really don't represent any of the organizations with which I'm affiliated, such as the Department of Veterans Affairs, U.S. government, or anything like that. As you mentioned, the work that I'm going to be talking about today is in no small part a product of the National Center for Post-Traumatic Stress Disorder, which is a national consortium funded by the Department of Veterans Affairs, and a new exciting collaboration between that entity and a consortium called StrongStar, which has been funded by the Department of Defense. So post-traumatic stress disorder reflects a wide range of problems that people have after they're exposed to psychologically traumatic events. And we think about post-traumatic stress disorder as having 4 general clusters of symptoms, including re-experiencing aspects of the trauma in the form of memories or dreams or even flashbacks, which are vivid re-experiencing experiences. Hyperarousal symptoms such as startle response, maybe even panic attacks. Numbing symptoms such as blunting of emotional responses or feeling mechanical or numb or having difficulty experiencing pleasure. And avoidance symptoms such as trying to push thoughts out of your mind or avoiding people, places, and things that remind you of the traumatic events. So we've known that these kinds of reactions have developed following traumas for a long time. And what I'm going to be talking about today are the various medications that are sometimes helpful for dealing with those symptoms. So far, we have only 2 medications approved for the treatment of post-traumatic stress disorder. They are both antidepressant medications. But I'll also talk about drugs which are designed to block the effects of noradrenaline and epinephrine, the fight-or-flight hormones of the body, drugs that block the action of serotonin, another important chemical messenger in the brain, and drugs that are used to facilitate signaling by the GABA system in the brain, which is the main inhibitory system in the brain. And then I'll finish up by talking about what I see as the future of medication development for the treatment of post-traumatic stress disorder. The first medication treatment for post-traumatic stress disorder, the antidepressant medications, were first tested not that long ago, 1988, by a group at the VA Connecticut healthcare system where our center is based. And this study compared the monoamine oxidase inhibitor phenelzine and the tricyclic antidepressant imipramine to placebo in people with PTSD. This study found that both imipramine and phenelzine were effective compared to placebo, and that these medications seem to be more effective for the hyperarousal symptoms and the re-experiencing symptoms compared to the avoidance symptoms of post-traumatic stress disorder. Strikingly, since both of these medications were developed and approved for the treatment of depression, the actual symptom of depression was one of the types of symptoms that did not respond very well to antidepressant medication in this study. With the emergence of drugs like Prozac, or the class of medication being the serotonin reuptake inhibitors, a new generation of pharmacotherapy studies in PTSD emerged. And the first medication to be approved for the treatment of PTSD was sertraline, also known as Zoloft. What you see in this study is the result of the first large evaluation of sertraline for PTSD. And what you can see is that the effectiveness of sertraline emerges very slowly, only significant at 10 weeks of treatment. That's much more slow than what we typically see in studies of depression. And a modest effect size. In other words, not a huge difference between drug and placebo. So we now have two of these types of medications, sertraline and paroxetine, which is also known as Paxil. And the profile of effectiveness of these medications seems to be a little bit different than what I described for imipramine, the tricyclic antidepressant. Sertraline, for example, seems to be most effective for the avoidance and numbing symptoms rather than the hyperarousal or re-experiencing symptoms. We have some sense now, after many studies involving these medications, that in the positive studies there's about a 10 to 20% benefit in terms of the magnitude of the reduction of PTSD symptoms compared to placebo. And that the profile of people who respond most favorably to these medications are people who've experienced single traumas rather than multiple traumas, people who are closer, relatively closer to the time of their trauma as opposed to people who have long-standing PTSD, females as opposed to males, and people without a complicating history of substance abuse. In fact, men with multiple traumas and chronic PTSD, a group that is not that uncommon in the Department of Veterans Affairs or other places of long-term treatment, that this profile was associated with the failure to detect efficacy of sertraline in a relatively large study led by Dr. Matt Friedman. One of the interesting questions which remains unresolved is whether these medications help to prevent acute PTSD from developing into more longer-standing PTSD. There are some studies, such as the one carried out by Drs. Murray Stein and his colleagues, that suggest that they may be helpful with recovery. But there is one cautionary study by Dr. Arik Shalev from Hadassah Hospital in Jerusalem and now at NYU, which suggests that that may not always be the case. And in their study, they compared placebo to citalopram to a control group called wait list control. They were waiting to be seen, to cognitive behavior therapy, and another kind of therapy called progressive exposure. At 5 months of treatment, there was not much difference between the prevalence of PTSD in the groups treated with placebo or in the wait list control. But at 9 months of treatment, people seemed to be worse off if treated with the SSRI citalopram relative to being on the wait list control, as if in some way in this group the citalopram, which is Celexa, S-citalopram, sorry, the S isomer of Celexa, was interfering with the capacity to be resilient, to recover quickly. Now, there are always limitations in studies, and the question of whether 10 milligrams was enough citalopram to draw a strong conclusion in the study is one of the complications of this particular study. But it is an interesting question and one potential concern about this class of medication. Because of the possibility that the serotonin reuptake inhibitor antidepressants, while helpful for many people, may leave some people ineffectively treated, other groups, such as our own at Yale, have explored other classes of medication. And in this study that I'm showing you here, led by Dr. Ismini Petrakis and published just a few years ago, what I'm showing you basically is the comparison of a drug that targets the noradrenaline system, called dizipramine, compared to a drug that targets the serotonin system, called paroxetine. And what you can see basically in this slide is that in this study, the dizipramine was just about as effective as paroxetine. And in fact, in some patients, it actually showed superiority to the paroxetine with regards to not so much the PTSD severity, but with regards to the ability to reduce heavy drinking among people who had comorbid alcohol dependence. Another question is whether the drugs that combine these modes of action, in other words, that block both the reuptake of serotonin and norepinephrine, these drugs are sometimes called serotonin norepinephrine reuptake inhibitors, or SNRIs, whether these would be more effective than the SRIs by themselves. And so here's a study from Jonathan Davidson's group showing that venlafaxine, which is one of the SNRI medications, was a little bit more effective than sertraline, again that's Zoloft, in the treatment of post-traumatic stress disorder. And what you can see on the far right corner of the graph is that at week 12, and that's the area with the circle, that the group treated with venlafaxine is about 5%, doing about 5% better with regard to the rate of remission compared to the sertraline group and compared to placebo. So there is seemed to be a little bit of a benefit of being treated with venlafaxine compared to sertraline in this population. So in summary, so far, pretty much all the medications that are used to treat depression that have been tested in rigorous studies in post-traumatic stress disorder have shown some signs of effectiveness, suggesting that there is some translation between the treatment of depression and the treatment of post-traumatic stress disorder. But the profile of effectiveness for these medications for the treatment of PTSD is a little bit different. The onset of efficacy is a little bit slower. The medications seem to be better for the negative, that's the avoidance and numbing symptoms, than the positive symptoms. And depression doesn't always respond in patients that have depression as a prominent symptom of their post-traumatic stress disorder. Sometimes tolerability can be an issue, requiring the initiation of these medications at relatively low doses and gradual titrations of dose to the doses where they can be effective. And in some chronic populations, particularly those that have shown already prior history of poor response to antidepressants, the rates of remission can be modest. So antidepressants are clearly the current state-of-the-art of post-traumatic stress disorder. They're the only medications approved for the treatment of PTSD. Yet it is worthwhile considering other classes that might be effective for the treatment of this disorder. So one class of medications that are drawing a great deal of attention are the drugs that block some of the action of noradrenaline. Now, noradrenaline is obviously the fight-or-flight system of the body, and in PTSD, using a variety of different kinds of chemical and physiologic measures, there is evidence of increased activity of the noradrenaline system and a relation between that activity and symptoms of PTSD. In the first study to rigorously show that, which we published around 1993, we gave people with post-traumatic stress disorder a low dose of a drug called yohimbine. Yohimbine activates the noradrenaline system of the brain. And when we gave people with post-traumatic stress disorder these low doses of yohimbine, some of the patients, most of the patients experienced some increase in their PTSD symptoms. And a few patients in the study began to have flashbacks. And here is just a brief segment of one person's experience who got yohimbine. We administered the yohimbine. The person got quiet, is sitting in a very quiet hospital room, and then starts to look upset. And I asked what was happening. And the patient said, "The helicopter's going down. I saw the flash of light and the smoke tail. It's crashing." What we saw was the first specific link between a biological mechanism, in this case, activation of the noradrenaline system in the brain, and the production of flashbacks, a cardinal symptom of post-traumatic stress disorder. We have since extended this work studying the neurobiology of the noradrenaline system, and using positron emission tomography and a particular molecular ligand, we were able to evaluate the density of the norepinephrine reuptake sites, also called norepinephrine transporters in the brain. Now, what we found was that in people exposed to trauma who developed post-traumatic stress disorder, there was a reduction in the expression of the norepinephrine transporter in the brain. In other words, lower level of those transporters. But people who had been through the same kinds of experiences but did not experience post-traumatic stress disorder did not show the same reduction in the density of these transporters. So let me just suggest a potential effect of the loss of those transporters. So normally norepinephrine, which is released by norepinephrine neuron, is rapidly taken up so that you have only a controlled activation of the norepinephrine receptors by norepinephrine. But if those transporters are reduced in their functional capacity, then every time the norepinephrine neuron is activated, that norepinephrine which is released hangs around in the synapse and extrasynaptic spaces for a longer time, giving them more opportunity to stimulate the norepinephrine receptors. So let's think about treatments that might be developed or applied based on the wish to attenuate the signaling of a hyperactive norepinephrine system. So norepinephrine can bind to the alpha-1 adrenergic receptor, and we now have drugs like the drug prazosin to block that receptor. And I'll talk about how that's been used to treat PTSD in research studies and in clinical practice. Another strategy would be to actually enhance signaling via the alpha-2 receptors, which are have the opposite effect, both presynaptically and postsynaptically, compared to the fight or flight effects of the alpha-1 receptor. And norepinephrine can bind to the beta receptor, which also contributes to fight or flight. And people have tried to block the beta receptor using drugs like propranolol. So let's review what we know about these treatments. Prazosin, which was developed to treat high blood pressure, has been used particularly in the studies led by Murray Raskind at the University of Washington. It has been used principally at bedtime, but increasingly both at nighttime and during the day to reduce symptoms of PTSD. When administered at night, it's been helpful with symptoms such as insomnia, nightmares, and waking up in the middle of the night. It's typically started at a very, very low dose because the body is very sensitive to prazosin. So it started at 1 milligram. And then after that, every 3 to 7 days, it tends to be increased by 1 milligram to a usual minimum level of 3 milligrams, which is often can be entirely at night or a mixture of at bedtime and during the day, to a maximum dose of somewhere around up to about 10 milligrams. Side effects can be low blood pressure and dizziness, as well as rapid heart rate. And so the dose increases have to be carried out carefully to watch for these kinds of side effects. We're now awaiting the results of a large multi-center study of prazosin to help us to understand whether this is a drug with benefits that are typical or generalizable across large groups of patients. Clonidine or guanfacine are the next type of drugs to tone down signaling in the noradrenaline system. Both of these drugs stimulate the alpha-2 adrenergic receptor, and these are receptors which play a role in the feedback inhibition of noradrenaline neurons in the brain and body. Clonidine, when it's added, is typically started at the low dose of 0.05 milligrams and increased gradually to 0.1 to 0.2 milligrams given 3 times a day. There are some studies that suggest that when given on top of antidepressant medications, that guanfacine and clonidine may be helpful for sleep or nightmares or hyperarousal. In other words, some of the same symptoms that prazosin has been reported to be helpful for. But overall, the studies have been a little bit inconsistent as to whether they're really effective compared to placebo for PTSD. The side effects of clonidine include sedation and low blood pressure, but these side effects can usually be managed by adjusting the dose. Guanfacine has an overall similar profile to clonidine and is continued to be studied, even though I'd say the data are not strongly supportive of guanfacine at this point. Beta blockers by themselves are very helpful for certain kinds of anxiety and stress. So for example, performance anxiety, where people get a surge of noradrenaline release and get tremors and some physical symptoms. Beta blockers are helpful for those symptoms, but have not been shown to be consistently effective for the core symptoms of post-traumatic stress disorder, neither in terms of treating chronic PTSD, nor really in a consistent way for preventing the development of PTSD when administered early on after a trauma. There is a hypothesized role for blocking the beta receptor to try to promote resilience. And the idea is that when people reactivate trauma memories, that those memories become open to revision, to rethinking, to reconsolidation. And that if you block the beta receptor, toning down the body's reactivity to these memories, that sometimes you may be able to change the memory from being highly charged to being a little bit more neutral. This hypothesis, which grows out of animal research, has yet to be conclusively supported by clinical research and remains only, in my view, an interesting possibility. So we have antidepressants, we have anti-adrenergics. Another class of medications very commonly prescribed to people with PTSD are the drugs that block the effects of serotonin in the brain. Why are we interested in serotonin signaling in PTSD? Again, my colleagues and I, in a study led by Dr. Steve Southwick, showed way back in 1996 that a drug that could stimulate some of the serotonin receptors in the brain, called M-chlorophenopiperazine, or MCBP, could worsen some of the symptoms of PTSD. And as we did with the noradrenaline system, we have applied a series of positron emission tomography techniques to help us to characterize the effects of serotonin dysregulation in the brain. And we've studied the serotonin transporter, or 5-HTT, which is involved in taking up and inactivating serotonin, as well as the key serotonin feedback inhibition receptor, or the serotonin 1B receptor. So how do we think this might work in PTSD? So what I'm showing you here is a pretend drawing of a serotonin neuron that has on it the serotonin transporter, or SERT, and the feedback inhibition receptor, the serotonin 1B receptor. And you also see that when serotonin is released, it can bind to a diversity of different receptor subtypes, 7, in fact, classes of serotonin receptors. So normally in the brain, as was the case for norepinephrine, when serotonin is released, it hangs around for a little while in the synaptic space and then is taken up by the serotonin neurons via the serotonin transporters. However, when the serotonin transporters are reduced, then serotonin spends more time in the synapse. But that may not dramatically change the regulation of the serotonin system, because serotonin also binds to the serotonin 1B, which prevents further serotonin release once a certain amount of level of serotonin is present in the synapse. But if, as in the case of PTSD, there is also a reduction in the density of the serotonin 1B receptor, the 5-HT1B receptor, we hypothesize that an important break of the system is lost and there's a more substantial release of serotonin into the synapse. So it may not be surprising then that medications that block some of the actions of serotonin, such as trazodone and nifazodone, are very commonly prescribed for PTSD, particularly for hyperarousal and insomnia and related symptoms of post-traumatic stress disorder. When my colleagues and I reviewed the medications prescribed in the VA, we found that trazodone was the most commonly prescribed medication in 2010, and yet there has yet to be a placebo-controlled trial of trazodone. So this is a case where clinicians have voted with their feet in advance of the data to really provide conclusive evidence of the effectiveness of trazodone. Trazodone is commonly started at doses of 25 or even 50 milligrams, and also commonly gradually increased, titrated to the point where symptoms are tolerably contained, typically 200 milligrams or below. Some people getting trazodone have problems with daytime sedation or headache, and it can cause a particular kind of erectile complication, priapism, in other words, an erection that won't go away, which sometimes has to be medically managed. This is an issue, particularly for young men, given that trazodone might be prescribed to soldiers, active military personnel. Nifazodone is started at 100 milligrams, can be increased to 200 or 300 milligrams twice a day, and there are some promising pilot data with nifazodone. Another class of medications, though, that is very commonly prescribed for the treatment of PTSD unites some of the strengths of trazodone and nifazodone with some of the strengths of prazosin. In other words, these are the second-generation antipsychotic medications. These are drugs that block the dopamine D2 receptors, like haloperidol or chlorpromazine. They block the alpha-1 adrenergic receptors. In other words, they have an effect like prazosin. And they also block the serotonin 2 receptors, and in this way have an effect that's a little bit like trazodone. So these are the very commonly known medications like risperidone, olanzapine, which is from Lilly, quetiapine or Seroquel, ziprasidone from Pfizer, clozapine, that's Clozaril from Novartis, and aripiprazole, that's Abilify from Bristol Myers Squibb. So my colleagues and I conducted the first large-scale test of the ability of a second-generation antipsychotic medication to assist in the treatment of PTSD symptoms from people who had chronic PTSD and who were taking other medications to try to help them with their post-traumatic stress disorder. This was a 6-month trial in 247 patients from sites around the United States. The upshot was that there was no significant benefit of risperidone in this study. We generally looked for a 10-point difference on this scale called the CAPS to indicate a significant clinical change. However, in this study, risperidone only produced a little over a 3-point benefit compared to placebo. There were some symptoms that seemed to be significantly improved from a statistical point of view. These were the symptoms of the re-experiencing and the hyperarousal symptoms as illustrated by this slide. However, these were not clinically meaningful improvements overall. There were some side effects, although not serious ones in this study. More weight gain in the risperidone group, more sleepiness on the risperidone group. But overall, risperidone was very well tolerated. the main issue was, here was a drug which has some potential for side effects. It has some cost associated with it, but did not seem to produce meaningful benefit. So we wondered whether anyone would really notice our finding when it came out. And as you can see in this slide, you can see the answer was yes. So the VA at that time was spending over $700 million on risperidone, and clinical practice had changed as a result. There are some caveats, which is that we were not studying psychotic patients in our study. And it's quite possible that other patients, particularly patients on fewer medications, would have shown a more pronounced response. Other medications are still commonly prescribed for the treatment of PTSD, such as quetiapine or Seroquel, which is predominantly prescribed in relatively low doses, starting at 12.5 or 25 milligrams, and gradually increasing to 100 to 200 milligrams. There are some small-scale studies suggesting that these medications are helpful. Other medications as well, such as olanzapine and aripiprazole. So these are the most commonly prescribed medications now for the treatment of PTSD: the antidepressants, the anti-adrenergics, and the anti-serotonergics. However, they probably weren't the first medication class which was used to treat PTSD. The first was probably the pro-GABA medications. And of these, the most commonly prescribed are the benzodiazepines. From 1999 to 2009, the prevalence of benzodiazepine prescriptions has begun to drop as alternatives to these medications have become clearer. The principal concerns about prescribing benzodiazepines for people with post-traumatic stress disorder is the liability to be abused or become dependent on them. And this is particularly the case for that large component of people with post-traumatic stress disorder who are vulnerable to developing substance use disorders. Perhaps in some ways the most important concern is that studies that have tended to evaluate the effectiveness of benzodiazepines, and I must say there's very little controlled data with these medications, have not really yielded much evidence of their effectiveness for the core symptoms of post-traumatic stress disorder. But I would argue that these are small studies given a very weak basis to draw firm conclusions. From a neurobiological point of view, we're very interested in the GABA system because it may very well be the case that GABA systems, that deficits in GABA systems are permissive for disturbances in other chemical systems of the brain that contribute to PTSD. In other words, the GABA system is a key system in the brain that regulates the excitability of the glutamate system, the norepinephrine system, the serotonin system, and other systems of the brain. So that it was very interesting that our center many years ago, now over a decade ago, in a study led by Doug Bremner, showed that there were reductions in the density of the GABA receptor binding sites in the ventral frontal cortex region of the brain associated with emotion regulation. And this was reductions in post-traumatic stress disorder, and you can see the region in the middle picture. When I said that deficits in GABA might be permissive of PTSD symptoms, I was referring to this study that we published in 2006. I mentioned before that PTSD evoked symptoms like PTSD, and that MCBP evoked symptoms like PTSD in people who had PTSD, but not in healthy people. So how could we show that the GABA system was involved in this propensity to experience PTSD-like symptoms in response to serotonin activation? So what we did is we created an artificial GABA deficit in healthy subjects by giving a drug called iomazanil which for the purposes of our discussion you might consider to be an anti-benzodiazepine. It is a GABA-A partial inverse agonist. MCPP by itself did not do much with regard to symptoms like dissociative states. But if we pre-treated with iomesanil, creating a GABA deficit, and then stimulated the serotonin system, you could see that dissociative symptoms emerged transiently but prominently in these healthy subjects. So it is possible that there is benefit from stimulating in a selective way the GABA system in post-traumatic stress disorder. The first study that rigorously tested this hypothesis, led by Mark Pollack, evaluated esapicolone, a drug which has some interesting properties because it has relatively high affinity for a subclass of GABA-A receptors, those that bear the alpha-2 and alpha-3 subunits, which have been particularly implicated in anxiety and arousal. Patients did reasonably well on esapicolone with a starting dose of 2 to 3 milligrams, and most patients end up being treated at 4 milligrams a day. There are other GABA modulators, two of which have been mostly negative so far, tiagabine and valproate, and there's a small pilot study with topiramate, which had some encouraging data, although a very small study. At this point, I'm going to switch now to be thinking about medication approaches that may emerge in the future. Drugs that promote neuroplasticity, rapid-acting antidepressants, anti-inflammatory medications, and medications that might promote the capacity for resilience. Now, one of the reasons that drugs that promote neuroplasticity might be an interesting strategy for the treatment of PTSD is that we know that some people exposed to trauma for decades after that exposure will hyperactivate their alarm systems in the body, such as the amygdala, when exposed to reminders of the trauma. And so the natural way to recover from that kind of what we would call conditioned emotional response would be to extinguish that conditioned emotional response. And we understand some of the underlying neurobiology of the extinction of fear. It involves a kind of new learning within the brain. That new learning, which depends on the activation of cortical inputs into the amygdala, is mediated by a particular subtype of receptor for the transmitter glutamate, the NMDA glutamate receptor. And so if we could facilitate the NMDA glutamate receptor while people were undergoing extinction procedures, as has been suggested by some of the work by Kerry Ressler and Barbara Rothbaum and others, it's conceivable that we could accelerate or accentuate the recovery from post-traumatic stress disorder. The drug that has been most intensively studied to achieve this end of facilitating NMDA glutamate receptors is a partial agonist known as D-cycloserine. D-cycloserine is an approved medication as an anti-tuberculosis medication, but at low doses it facilitates NMDA receptor signaling, binding to NMDA receptors in the presence of glutamate and enhancing the opening of a calcium channel, allowing calcium to enter nerve cells, exciting these nerve cells. As I mentioned, D-cycloserine has been helpful for facilitating fear extinction for a variety of other disorders, particularly phobias. But so far, the findings in post-traumatic stress disorder are not very strong. So it remains to be seen whether this will really emerge as an effective treatment. Mainly the concern is that if you enhance plasticity, you may unwittingly also enhance the consolidation or strengthening of fear if you don't do it right. A new exciting class of medications, and one which we have helped to discover, are the rapid-acting antidepressants. Now, this is interesting with regards to post-traumatic stress disorder, in part because we know that stress has some detrimental effects on the structural connectivity of the brain. And what you're seeing here is a study showing that the inputs into nerve cells, the dendritic fields, regress or atrophy, particularly in the context of severe or chronic stress in animals. We went on to test a drug called ketamine, and as you can see in the top row, what you see is that from a single dose of ketamine, that a group of people who had refractory depression improved in their depression over a very short period of time. They started to show benefit within 4 hours, and about half of the patients had responded within 24 hours. And the interesting thing of that study was that the usual effects that people pay attention to of ketamine had long passed. In fact, they had been gone for about 2 hours before we really detected clinical improvement in our studies. This suggested that some kind of reaction within the brain was responsible for the emergence of the antidepressant effects of ketamine. What Ron Duman and his colleagues showed was that one of these reactions in the brain was to have a very rapid regrowth of synaptic connectivity in the form of dendritic spines, the connections that dendrites make. So it's conceivable that ketamine and other rapid-acting antidepressants, such as scopolamine, may play a role by producing rapid regrowth of synaptic connectivity, which has been lost as a consequence of stress. This is an exploratory hypothesis. There are studies now underway at Mount Sinai and one starting in our center to see whether ketamine will be a helpful strategy for regrowing synaptic connectivity in PTSD. Inflammatory agents are another class of medications. And we know that stress and traumatic brain injury promote inflammation in the brain. And this inflammation contributes to distress, depression, and negative structural changes in the brain. At least that is the current working hypothesis. And so there are emerging strategies for blocking these cytokines. Drugs like infliximab, which blocks directly one of the inflammation signaling mechanisms in the brain called TNF-alpha. And there are other drugs which have anti-inflammatory effects, such as the antibiotic minocycline and the drug riluzole, which has been used to treat most commonly amyotrophic lateral sclerosis, or Lou Gehrig's disease. Another recent strategy, also not yet evaluated in post-traumatic stress disorder, has been to use a medication called N-acetylcysteine, or NAC, which raises glutathione levels and protects cells against inflammation. I'm going to finish by talking about promoting resilience. There are a number of mechanisms that have been implicated in the capacity of the body to cope with stress. Going all the way back to the groundbreaking work of Hans Selye, glucocorticoids have been well known to enable the body to cope with stress. And there is new interest in the possibility that people who go on to develop PTSD may have difficulty mobilizing sufficient glucocorticoid release to adequately cope with stress. And so there are now studies under the way and some interesting preliminary data that in the initial post-stress period that glucocorticoids might play a protective role in stress. The most intensively studied medications, predominantly by accident, have been the opiate receptor agonists like morphine, which have been given to patients in the moment of their physical pain in the context of burns or injuries, and have appeared to show some benefit in reducing later emergence of PTSD symptoms. A novel mechanism which has been implicated by studying people undergoing severe physical and psychological stress is neuropeptide Y, which helps to shut down the arousal systems in the body. And there's now the very early stage exploratory stages of a clinical trial of neuropeptide Y. So these are mechanisms that may help prevent people from developing PTSD. They're all in very early stages, and we'll have to see whether they withstand the test of time. So in summary, I've told you about the standard treatments, the serotonin reuptake inhibitors, which are very helpful for many people, but still leave some people inadequately treated. Other medication classes, such as the norepinephrine reuptake inhibitors, the anti-adrenergics, the anti-serotonergics, the second-generation antipsychotics, and some medications that might facilitate GABA systems, are all showing some promise for PTSD. But none of these classes have received a definitive test that has definitively endorsed their effectiveness. There are many open questions, particularly how do we figure out how to best match a particular medication with a particular patient. But these are going to be the areas that are going to receive increasing study as we move forward. Lastly, I just wanted to acknowledge that when I talk about treating PTSD, and that in most of the clinical research studies, they're treating people who mostly just have PTSD. And yet we know that in the real world, post-traumatic stress disorder can be a very complicated condition, complicated by drug abuse, comorbid depression, traumatic brain injury, chronic pain, other psychiatric disorders. So we're making progress, but we have a long way to go. And these are going to be, the good news is that there's a lot more PTSD research now than there used to be, and hopefully we'll continue to make progress. Let me conclude again by thanking BBRF and Jeff for the opportunity to speak to you today on the day after Veterans Day, and to acknowledge my colleagues and collaborators, both past and present, at the Clinical Neuroscience Division at the VA National Center for PTSD. At this point, I am happy to open it up for discussion.
Great. John, thank you so much for an extraordinary presentation on a complicated topic, but one that you explained in a way that lay people can understand. And I also want to thank you for your ongoing work to help find improved treatments and ultimately methods of prevention and ways to cure post-traumatic stress disorder. I want to jump on what you brought up at the end, which is the issue of comorbid conditions, and just ask if you could impart some of your clinical wisdom to people who may be listening right now who do have some of these comorbid conditions, whether it be chemical dependency, depression, traumatic brain injury, etc. What do you suggest when those conditions are combined with post-traumatic stress?
Well, Joseph, those are great questions, and they're real-world questions, since these kinds of comorbidities are very common complications of post-traumatic stress disorder. Let me try to address each of them briefly in the order that you raised them. So the first question that you had to do with substance abuse, alcohol and substance abuse. It's very interesting if you actually look at the overall frequency of diagnoses or problems that people come back for war with. It turns out that smoking and alcohol abuse and dependence are actually, if anything, more common in the returnees from Iraq and Afghanistan than post-traumatic stress disorder, at least initially. And it may be partly because in these extremely pressured environments, a variety of factors come together that increase the likelihood that people will try these substances to either soothe themselves, to help with sleep, to let off steam, to connect with other people, a variety of reasons that people will try these substances and find them comforting. However, once you get back, most of these medications, particularly the alcohol, are a huge problem. So with alcohol, alcohol is a problem in so many ways. One of the biggest ways that alcohol is a problem is that when people are trying to recover from exposure to extreme stress, there's often a feeling that they're trying to manage emotions which are intense, which intrude into their lives and which are difficult to manage, to push out of their mind so that they can focus on what they need to do. Alcohol impairs the ability of the brain to push these kinds of ideas out of the mind, so that people, rather than making these thoughts and feelings go away when they're drinking a lot, often find themselves flooded by the thoughts and feelings. Secondly, not only do these drugs interfere with the ability to push these thoughts and feelings out of your mind, but they also impair the ability to control one's impulses, so that people who are drinking heavily are more likely to express their anger or irritation in a physical way, by shouting or yelling or threatening or fighting or throwing things around. And so it's a double whammy in terms of interfering with the adjustment that people are trying to make, because family members, employers, friends can become afraid of this kind of disinhibited impulse and make it harder to reconnect. So there are a variety of strategies that we use, some involving medications which are primarily developed for the treatment of alcoholism to help people manage the alcohol part. So, for example, there's a medication called naltrexone, which is helpful for some people to manage their drinking. There's another medication which we haven't found to be very helpful called acamprosate, which is approved for the treatment of alcoholism, and we actually don't use it that much. Naltrexone we prescribe. For some patients who are living with other people, such as family members who will supervise the administration, we will also sometimes prescribe a drug called Antabuse or disulfiram, which is a very powerful medication which makes people feel ill if they drink when they've taken disulfiram. And so compliance is not very good with this medication, so usually we prescribe this drug in the context of a supportive family or social environment. But we think getting help for the drinking is critical, or getting help for the substance abuse is critical, and that the whole picture has to be seen as one interacting problem. So we try to make sure that when people are presenting for treatment, that they get the help that they need, not only for their post-traumatic stress disorder, but for their alcohol or other substance abuse problem. Traumatic brain injury is a double whammy. It's like being intoxicated with alcohol. Traumatic brain injury can make it harder to focus one's attention, to push thoughts and feelings about the trauma aside, and to suppress impulses. And so if someone has got traumatic brain injury and post-traumatic stress disorder, we try to focus on skill building. How do you manage anger? How do you manage your anxiety when it comes up? Strategies to learn how to relax. Strategies to learn how to manage the urge to react in a strong way. And the psychosocial part, the therapy part, is just as important as the medication part for patients with PTSD.
John, let me interrupt you because we're going to be running out of time momentarily.
Okay. So in a nutshell, we then have to titrate very carefully because people with TBI are more sensitive to side effects. Maybe I'll just let you go into another question.
Yeah, I think what I'm going to do, because we have a minute left, I want to wind up, and it sounds like what you're saying in summary with regards to the comorbid, and each condition has details that relate to it, is that you can't treat one without treating the other. Both need to be treated concurrently, and you need to take into account each of these conditions fully when treating the person.
Absolutely. Whether
it be alcoholism, TBI. John, I want to again thank you for an extraordinary presentation and for your ongoing work. Certainly, your research and the research of others gives tremendous hope to people, and the fact that treatment is available is crucial for people to realize. I also want to thank our audience for joining us today. The foundation is dedicated to improving the lives of people with a wide range of psychiatric conditions. All of the research we fund is made possible through private donations. So if you'd like to make a gift, please visit our website, bbrfoundation.org, or call 1-800-829-8289. The webinar has been recorded, so if you've missed any portion or would like to suggest that a friend see the webinar, please do so. It can be seen on our website. And I hope that you all join us again next month on a different topic. We will hear from Dr. Fred Volkmar, Professor of Child Psychiatry, Pediatrics, Psychology, and Director of the Yale University Child Study Center at Yale. He will speak about autism, progress, and promise for the future. And that will take place on Tuesday, December 10th at 2 o'clock Eastern Time. Once again, thank you everybody for joining us, and John, thank you for your presentation. Take care, everyone. Bye-bye.